Welcome. It's quite a pleasure being here. Though when a cardiologist speaks in an oncology conference, it's a little bit like a foreign language speaker. But that's part of the fun of it. When I was a medical resident a couple centuries ago in the Dark Ages, the only thing we worried about was anthracycline toxicity, which was certainly more liberal in use then and in dosing. But in today's world, there are a number of drugs that are in use, and there's an increased focus likewise on preparation of the patients. The more we look at oncology patients with the more sophisticated tools, is the more we find that many things lead to adverse cardiac outcomes. And in addition to that, the key characteristic is that, at least in the case of left ventricular dysfunction, which is my particular interest, it matters if you, let me see if I can get this pointer okay, I'll pass on the pointer, but then it matters to, is that, it comes on now? Let me see. Yes, okay, fine. So there we go. It matters if we start off by selecting patients and recognizing that if we optimize their care in this phase, when the oncologist identifies the candidate, that we can then help prevent some of the adverse outcomes that occur later on when we find them deteriorating during active therapy and even beyond. This is the assessment, therefore, of baseline cardiovascular toxicity risk is a big thing because if you can assess who is at risk, then we could decide who are the people who need to go on to more advanced evaluation with complementary tests which are identified here. More importantly, everybody, however, needs to have a clinical assessment based on what they've had before, what is their cancer treatment history, and whether or not there's any evidence of cardiovascular disease or dysfunction. It is this clinical assessment done by the oncologist that determines who needs to go on to further evaluation. But the more you look, the more you find. And this is a slide from the current edition of JACC Cardio Oncology, just to show that if you look enough, you'll find that this is in lung cancer therapy, not just targeted therapies, which are here, but pretty much whatever treatment you apply to the treatment of lung cancer, even whether it is ICIs, chemotherapy, radiation therapy, surgical, non-drug therapies, there is the potential for an adverse cardiovascular outcome. The point I'm making, therefore, is that one has to have a tailored approach to manage, because everybody can't be seen by the cardiologist. And therefore, it is very important that one have a structured approach to determine who are the highest risk patients and which are the highest risk therapies, to select who requires cardiovascular evaluation and optimization prior to initiation of chemotherapy. And there are these, and I'm here charged with speaking to his two therapies, which are in the this column here. And we could see that, thankfully, all cardiovascular adversities are not created equal. And certainly, the greatest risk comes from the cardiomyopathy and which is seen up here, and is very high with both the anthracycline, which I would say I grew up on, and now HER2 targeted therapies as we go along. But it's not restricted there. There are risk factors for this, and as we could see, if patients have impaired left ventricular function, which you see here as an ejection fraction under 50%, then this automatically puts them at high risk. So one can select the patients who are at higher risk and consider those people going for pre-evaluation by the cardiologist. And of course, the elderly, as we identified here, the older you are, the more you're likely to suffer an adverse outcome cardiac-wise. So this comes from the European Society of Cardiology, their joint guidelines, and they've set from 2022 a class 1 recommendation. All patients should certainly have an ECG, and if your ECG is abnormal, it's wise to have that person see the cardiologist. Secondly, as a class 1 indication, European Society of Cardiology recommends the possibility of doing a BNP and a cardiac troponin, cardiac markers for injury. This, I think, is very dependent on your resource limitation or how well resourced your system is, because you're generally not going to make decisions at this point based on this, but it provides a baseline, especially if there's a likelihood that as a joint collaboration, one is going to use this going forward, so it's useful to know where the patient is. But especially in resource-limited environments such as we are here in the Caribbean, some discussion has come up, do we need to really adopt all these things as class 1 recommendations? The big thing that really hovers and determines a lot of what we do is the echocardiogram, bearing in mind that our concern has to do with left ventricular function in the HER2 patients. And the class 1 recommendation for echocardiography is when one is either going to use a cardiotoxic agent, in this case we're specifically talking about targeted therapies, and if you are, then it is best if one can use ancillary measurements such as 3D echo and GLS, which is global longitudinal strain. Well, I mean, these are, how does the oncologist relate to this? I'll see a little bit more. But certainly a baseline echocardiogram is essential if one is using potential cardiotoxic agents. And it's recommended, of course, that we stratify patients for cardiovascular risk prior to initiating therapy. And this should be a joint recommendation using the multidisciplinary approach. And certainly I get a number of phone calls from certain oncologists regarding clarification of a patient's status and what is contemplated. And that helps a lot, as I will indicate later on, because you can either have a simple answer or you could have a more insightful answer and to the evaluation of patients. The last line is important in this slide, which is that if the patient is at low cardiovascular toxicity because they're not receiving an agent that has a high cardiovascular toxicity risk, and the patient themselves does not have any abnormality on the ECG or any features of that would predispose him or her to a particular risk, that one proceed right away with initiation of drug therapy without waiting too long to deliberate on the cardiovascular risk profile. And this is summarized here, where patients are identified here after their diagnosis between low, moderate, and high risk. And you can see that the low-risk patients should have standard surveillance and annual assessment of their risk profile, whereas the high-risk patients down here should all be referred for cardiology assessment, so that any remedial work or in preparation can be done to get these patients on to therapy. And indeed, they should have annual follow-up and transthoracic echoes in at least alternate years ongoing. So this is summarized here in this slide, which basically reiterates. Just to say that two things that as we learn more and more about prevention of cardiotoxicity, the basic things like hypertension are very important, not just from patients developing hypertension as a complication of their drug therapy, but pre-existent hypertension, which in our population is quite prevalent and often quite severe. Poorly controlled, either because of hypertension resistance, high-resistant hypertension, or because of resistant patients who don't want to take poor compliance with the antihypertensives. Doesn't matter. It's important to control blood pressure, because there is a threshold now recommended to withhold therapy, which is systolic blood pressure greater than 180. So blood pressure 180, 110 is sufficient reason to withhold and delay therapy until this can be controlled. And of course, at the lower levels of hypertension, treatment control can be optimized even while one is initiating therapy. And of course, hypertensive emergencies require stopping therapy and dealing with the crisis on board. The other comorbidity is diabetes that I'd like to just briefly focus on. And this again comes from a study published last year in JACC Cardio-Oncology journal, which shows that in today's world, whilst the ESC guidelines, which are the usually reference guidelines that we go to for cardiac evaluation and treatment, is focusing on trials to create evidence-based. The treatment margins have gone on beyond that, although there are not yet any good prospective studies. We know that in diabetic patients who are more prone to cardiac disease at baseline with or without cancer therapy, we have the use of the new agents, which is the SGLT2 inhibitors, now being even used in non-cardiac patients in heart failure therapy. But the word to the wise is that if one is going to use targeted therapy, if one is going to do KERS2 therapy, trastuzumab, and so on, it is probably a good idea to get these patients, and they're already on drug therapy. It makes sense, if budget allows, to have them on SGLT2 inhibitors, because we can see that there's a distinct difference in outcome. This being a retrospective study, this is not a prospective study, but you can see that SGLT2 cohort have a better survivorship and better outcomes than the patients who are not on SGLT2 inhibitors. So controlling diabetes is not enough. It also matters what you control them with if you want to try to avoid cardiovascular outcomes, or if you want to minimize the therapy. So depending on what drugs you're going to use, there's this whole list of choices and pathways, which is a little bit confusing, but I'm going to drive you to this slide, which shows, and there's two targeted therapies which should be considered. Here is the high-risk patients. They should have an echo, and as I said before, it's recommended that they have both the serum markers of BNP and cardiac troponins. similar to the high-risk anthracycline patients who should have all of them done. In the lower-risk patients, certainly they should all have echoes done, transthoracic echoes, and one can certainly be more discretionary on the biomarkers. Which brings us now to the period during therapy, which is where we tend to see all the action going, especially if patients have not been prepared. And I want to remind us of the two prototypic types of injuries. There's the type 1 injury, which occurs with the anthracyclines, and this historically is the one that, as I said, was first recognized and through the red flag. And the injury here, when somebody on anthracyclines goes into heart failure or drops the ejection fraction significantly, there's a large component of myocardial necrosis. There's cell death. The more you give, the more cells die. They're not going to come back. The cells aren't going to come back, even though with modern treatments, we can now improve the heart failure function and get the patient back into a good situation. With the targeted therapies, which is our focus here, across on the right side of the slide, you can see that whilst for the similar drop, there's a greater chance of recovery of the cells, and therefore a different logic applies in recommendations on anthracycline patients versus his 2 therapies. And I think there's a great benefit to collaboration between the oncologist and the cardiologist as to what is a reasonable point to stop therapy, what is a reasonable point to restart therapy, and how much is permissive therapy. In other words, its heart function is decreasing, but we recommend that it's okay to go on. This requires an educated and informed cross-disciplinary input from both the cardiologist and the oncologist working together. And I like to use, and when you order an echo, you could get a ton load of measurements, you know. Some of the echo reports, you'll see there are 3 pages of numbers, and what does the oncologist do? I often wonder what the oncologist does with all of those numbers in front of them. And to just tell you that, and of course the ejection fraction is the key thing. Usually we would have the 2D traditionally ejection fraction, which what nobody likes to admit is there's a high degree of variability. If you go from lab to lab, you'll see difference. And even within a lab, there's a certain amount of variance that you'll see in the ejection fraction. So when is it significant? When is it not? Of course, if it's more than 10%, it's usually considered significant. But because if you're using 2D echocardiography, you will certainly, it depends on how you slice, technically how you slice the ventricle. So now it's recommended to try to do 3D transthoracic echo, which thankfully is now available, and also to add on global longitudinal strain, which is an ancillary function. We won't discuss too much more of it here, but this helps the cardiologist in his or her recommendation of how serious this thing is. This is a super person where the function looks like this. It's all nice and red, but there are different patterns of injury, and certainly this person is a sick cookie, even if they've still got a normal ejection fraction. So somebody with a map that looks like this is much more likely to be advised to stop than somebody who has a map that looks like the other. And so in thinking about this, and I understand we have representatives and speakers from these illustrious universities, and I'm looking at their logos. You know, for the first university in the United States spoke to Veritas as its thing, which is a search for truth. And if that's all you want, then yes, you can get an ejection fraction, which is fairly accurate with the 3D and global longitudinal strain. But if what you want is an enlightened truth, contextual information, to make the difficult decisions, then it's important how you send your requests. If you're not in a fully collaborative cardio oncology clinic, and you're running a busy state clinic, for example, and you're sending out requests, it's important to include the full diagnosis and the context of your therapy, whether this is curative, whether it's adjuvant therapy, and it helps in the recommendation that the cardiologist made, which should in any case be very conservative. And so the things that we have to decide on is whether it is severe, the severity, and their criteria. If the person is hospitalized and crashing, obviously that makes a difference from when the person is just mildly symptomatic, in which case therapy will be ongoing. And even in asymptomatic patients, if you have an ejection fraction that drops below 40%, and especially if it's buoyed by abnormal global longitudinal strains, then a more appropriate decision can be made. And I think I've just been stopped because we've run out of time. So, okay, no, well, we've been granted a reprieve. And I'm just going to go quickly. But even after completion of that phase, we need to go on to the survivorship, because during the survivorship, there needs also to be continued surveillance, because there can be deterioration. And this, in summary, is what it looks like. Patients need to have transthoracic echoes at baseline, at 3 months, 6 months, and 9 months, and then at 12 months, and then post-treatment up to a year. And this is especially so in the very high-risk patients. In low-risk patients who are not getting into trouble, if the ECG is fine and nothing happens to them during therapy, there's no need to burden them with the added cost and inconvenience of serial echocardiography. And so there are recommendations that have to do, which are based on the baseline risk, and also whether or not there has been a drop in ejection fraction during. And I'll just take you to my last slide, if I will, and which, again, doesn't come on. And this just says the recommendations will be different if it's metastatic disease versus if it is curative disease. And with that, I'm going to ask that we have I'm going to appeal for collaborative and interdisciplinary discussions between cardiology and oncology, so that we can make more informed decisions for our patients. Thank you.